the hot topic with respect to practitioner groups at this time is there seems to be a lot of denouncing of the fact that there's too much opioid use, and everyone is looking for ideas to minimize the use of opioids. But one of the top suggestions that people consider is maybe non-opioid and non-pharmacologic treatments, which is fine. The problem that we have is everyone is overlooking the main problem to begin with, which is being, how do you address the problem that the patient's in for which you are trying to address the pain that they have? Because many times there is an alternative option where you can step back, take a different look at the clinical picture, find an interesting way of handling that patient to come up with a more appropriate clinical diagnosis, and maybe alter the treatment so that you can minimize the need to prescribe an opioid or medication to begin with. I mean, there are so many patients that we've seen over the past couple of really decades that I've been in clinical practice, where we have done nothing different except to take a step backwards, reevaluate the patient from an entirely new perspective, come up with a new working clinical diagnosis, and then treat a problem to resolution that somebody was managing for chronic pain for often years without resolution. So I don't necessarily think we have to look for new means of treatments, but we have to look for better ways of triaging the treatments that we have. You know, not every patient is going to respond to every single treatment. The problem is we group things together like back pain as a single entity, when back pain itself is a symptom, not a diagnosis. So the diagnosis should be, let's say, facet-mediated back pain, which might be an inflammatory pathology. When we should recognize that that same inflammatory pathology with respect to the facet joint might inflame a nerve root causing a radiculitis. So then the most effective treatment would be to somehow control the inflammation of the nerve root and the facet joint so that we can treat it to resolve it. Why do we have to mask the pain or overshoot the problem by, let's say, injecting a facet joint and, ooh, that didn't work, but you missed part of the problem, so it came back a few weeks later, we did a transfemoral epidural, and, well, by that time the facet's re-inflamed and we feel like it's the dog chasing its tail. You know, there are other times where it could be something as simple as a patient is overtreated. Some of the patients that we've seen even in recent years, and I'm only practicing part-time these days, if any, and we see these patients that are on multiple medications by multiple providers for multiple problems because everybody's looking at the patient from the perspective of their own specialty, which is very narrow and focused, and sometimes the patients don't even link the pieces together and they're trying to treat each problem as if it's independent. Well, how many of the antidepressant medications do we have that also bleed over into the pain community? So if we can modulate or influence the system, if you will, by putting these patients on these medications, which is what we're doing because we're influencing them, we're really not controlling them, how do you know that that anxiety medication is not going to play a role in what that patient's perception of pain is? We've seen so many patients that all you literally have to do is address the medication profile they're on for another disease state, and all of a sudden their pain issues resolve. So it seems to be, the question is, I think, a little bit different. It's basically, how do we center care or create more of a patient-centered model, which I think would improve our outcomes to begin with, and then we can be a little bit more careful with respect to the care that we're providing a patient.